everyone. My name is Dr. Cooper. For anyone who doesn't know me, I'm one of the naturopathic doctors here at Living Wellness Medical Center. And today I wanted to do my webinar on EDS. So this is Ehlers-Danlos Syndrome. I wanted to do it on EDS because I've been seeing more and more of it clinically. It's an area that I have taken some personal interest in. And a lot of my patients don't know about it when we start to connect some of the dots of some of the things that they've been experiencing, then it sometimes does pop up. So I wanted to do a webinar on it for any of those patients who, again, either have EDS. If you do have EDS, this might not be the most elucidating PowerPoint. You probably know most of the information on here. This is really more of an introduction. But if you don't have EDS and joint hypermobility or connective tissue have been, kind of like keywords that you've heard throughout your life, if someone's told you, oh, hey, you're really hypermobile, or your joints move in a way that I wouldn't expect, then this is something that I definitely want to be on your radar. So let's go ahead and get started. So what is EDS? So EDS is more of this umbrella. There's 13 different types of connective genetic tissue disorders. And so they're caused by genetic changes that affect the connective tissue. Each different type of EDS has its own set of features, and there's distinct diagnostic criteria for each of them. And so all of the types, except for the hypermobile type, which is what today's presentation is going to focus on, has genes that are affected that are known, and then also has specific proteins that are identified. And so for EDS, for the hypermobile type, those haven't been established yet. And so common features for EDS, so for all of the EDS, is joint hypermobility, skin hyperextensibility, and then tissue fragility. So joint hypermobility means that you have joints that move in a wider range of motion than what would be considered, quote unquote, normal. And then skin hyperextensibility, so your skin is a little more stretchy. Tissue fragility, this can be seen in a variety of different ways. So poor wound healing, easy bruising, easy bleeding. Those are some of the kind of common explanations for those. And then the hypermobile type. So the hypermobile type accounts for about 80 to 90% of all of EDS. And so it's by far the most common. And so that's what I wanted to focus on today. Most of my patients that I see with EDS have the hypermobile type. And then of the patients that I see that I'm suspecting they may have EDS, most of them, end up having the hypermobile type when we dig a little deeper and go through the diagnostic criteria. And so with that said, let's look at the diagnostic criteria. So the diagnostic criteria for HEDS can be found online. If you wanted to have a copy of this yourself, you can just Google the 2017 criteria for hypermobile EDS, and then you'll see this document. It's separated into 3 different criteria, and so we'll talk about each of those. Hopefully I can zoom up a little bit so I can read these. I'll probably bring it up on my slide set. Okay, so the first one is generalized joint hypermobility. So this typically I have people kind of work through this. We work through this in the office together. If we're suspecting this for the first time, typically if someone's already been diagnosed, they've gone through this either with their primary, with a rheumatologist, with a different provider. And so the first is this generalized joint hypermobility. And so you'll see that there's different cutoff for different ages. And so children and adolescents, we have to have 6 or more of these positive. For men and women up to age 50, more than 5 or 5 or more. And then above 50, 4 or more. So then you'll see on the right-hand side of this screen, there's different pictures. And so these pictures are showing what needs to be present. And so there's a total of 9 that you can get if you meet all of these. So again, either greater than or equal to 4, 5, or 6. So the first one is, can you stretch your pinky back about 90 degrees or more with your hand flat on the table? So you'll see that one all the way to the left. So you get a point for left finger, right finger. And then the next set is, can you take your thumb and touch it to your forearm? I won't demonstrate these, but there, you get a point for one side or the other side. And then the next is, do your elbows hyperextend? So a point for each side. And then do your knees hyperextend, a point for each side. And then the last one is just a point, if you can do that. And that is, can you put your hands flat on the ground without bending your knees? So you'll see there you can have a total up to 9. And so that's something that I'll either ask people. Usually I don't like them to demonstrate. You likely know if you can do this. Some of them, if you don't know, with the elbow hyperextension, then of course we'll look together. And then the next point, we have some additional information if you're a point kind of below the cutoff. And so that is, could you now or could you ever do some of these things? So you'll see the first two. And then I love that this one's in here. I don't know. I just find it kind of endearing given my personal history. Is, as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? And that's more so without trying. So a lot of people that do have EDS or hEDS, I have seen that they have a history of being a gymnast, a dancer, in some type of sport where some of the benefits of being flexible were kind of praised. And they were given like, oh, wow, you can kick your leg really high, or you can do the splits without trying. And so that's something that I'll usually ask people about too, is their past history. And then there's a point on here about, did you dislocate your shoulder or your kneecap on one or more occasion? And then do you consider yourself double jointed? So that's some additional points where you can get some of those if you're just a little bit below that cutoff. And then next we have the second set of criterion here. So you'll see there's feature A, B, and C. So 2 or more must be present. Feature A, I'm not going to read through all of those, but 5 or more of those need to be present. And so that's something I'll typically go through with people. Some of this we might not have access to. So we might not know if you have a mitral valve prolapse. That's something that we could do some imaging to get some additional information. If, let's say, you're close to that score and we want to do some more imaging, we can. And then feature B, family history of someone meeting this, because again, it is genetic. So it's going to typically run in families, and it has an autosomal dominant pattern, meaning that if you yourself have EDS, the hypermobile type specifically we'll talk about here, because I know that that one's autosomal dominant. The other ones, I believe most of them are, but I don't have those memorized. And so don't quote me on that. But that means that there's a 50% chance of your child also having EDS. And then feature C, so you must have one of these. So do you have pain in 2 or more limbs recurring daily for at least 3 months? Do you have chronic widespread pain for more than 3 months? Or do you have recurrent joint dislocations or frank joint instability in the absence of trauma? So that's that second part of this diagnostic criteria. And then we have a third part. So in this third part, this is more so ruling out other things that could present similarly. And so absence of unusual skin fragility, which should prompt consideration of other types of EDS. So the other two, I would say, next prevalent types is the classical type and the vascular type of EDS. We're going to talk about genetic testing, I believe, on the next slide. And sometimes we will do some genetic testing to rule out other types if there are symptoms, family history, suggesting that those might be positive. And then number 2 would be exclusion of other heritable and acquired connective tissue disorders, including some autoimmune conditions. So you can read through that. You can have an autoimmune condition though, and hypermobile EDS. And so having an autoimmune condition in and of itself does not necessarily mean that you can't also have hypermobile EDS. And then the third is exclusion of alternative diagnoses that may also include some of these main features like joint hypermobility. And so that's that third part of that criteria. And then next is the genetic testing. So of the rheumatologists and geneticists that I know, most are doing the INVITE, which is the EDS panel, which again is the focus of that typically, because hypermobile EDS is the most common, is to rule out the other types. If the other types are ruled out and you have met that diagnostic criteria, then typically you're given the diagnosis of hypermobile EDS. This doesn't always need to be run from what I've learned, but it is something that can give people peace of mind to know more, make sure that any of the other types that are much less common are ruled out because they tend to have more significant impacts in terms of surgery, cardiovascular health, and risks. So, and then this, I love this picture. This is from the EDS Society. A lot of this information is from the EDS Society or my additional trainings that I've done. But I really like this picture because this picture highlights that EDS is really a spectrum. And so it's not like mild, moderate to severe. It's usually what symptom of the symptoms that are very common with EDS is more prevalent for that individual. And so you'll see on the left-hand side that at the bottom, you have the joint instability, you have mast cell activation syndrome or MCAS, there's pain, there's fatigue, there's GI issues. And so you kind of have this like little, I would say, assortment of different symptoms. And that really is what drives treatment, which we'll talk about much later in the presentation towards the end. And then the right-hand picture is, again, showing that a little bit better in terms of someone with EDS can have more of these symptoms present, whereas other people can have other symptoms present. And then another thing that I did want to point out was that you'll see the left side, it says the HSD spectrum. So that's hypermobile spectrum disorders, whereas EDS is Ehlers-Danlos Syndrome. And so HSD and EDS, they're not synonymous, but there's a lot of varying thoughts and opinions. Some people think that HSD is just like a more mild form where you don't necessarily meet all the diagnostic criteria for hypermobile EDS. And so you're given that diagnosis more of hypermobile spectrum disorders versus EDS itself. Other people say, hey, these are essentially the same thing, because you still are going to go through that buy-in score when we're looking at that joint hypermobility. And so you might see these terms used synonymously in literature if you're digging in, but I just wanted to highlight that difference. And there is a lot of good information on the EDS Society's website about HSD and then EDS itself. And so now we'll go through some of the common symptoms. Symptoms can be present in truly any category because we have connective tissue and we have collagen everywhere in the body. And so we'll go through some of the more common symptoms, and then at the end, again, kind of like circle back to treatment a little bit. So in the musculoskeletal or skin symptoms, there can be many, many things going on. We can have chronic pain, we can have muscle tightness. So our muscles are trying to make up the job of the connective tissue or of the, let's say, ligaments that might not be as strong or have as much integrity. And so our muscles can get really tight to try to keep our body in space, to try to hold everything in together. We can have muscle spasms, we can have subluxations or dislocations. Classically, I see these more in the knees, in the shoulders. Some people can have hyoid bones, so their hyoid bone can subluxate. You can have recurrent sprains, tendon or ligament tears. So again, another pretty common symptom that I hear is, you know, as a child growing up, just constantly spraining your ankle. You just fell in slightly the wrong way, and then you had an ankle sprain that lasted for weeks. You can have soft and stretchy skin. You can have easy bruising, easy bleeding, atrophic scarring, and then also poor wound healing. Another thing that I wanted to talk about on this slide is that there are different phases of hypermobile EDS. And so you can have different phases present kind of linearly throughout your life, or kind of dip in and out of those. And so let me pull up my slide that I have. So yeah, you can have the hypermobility phase, which is typically more seen in early life, where you have that joint hypermobility and the ligamentous laxity. And so here we can see more sprains, dislocations as we're younger. This is like the fun phase, as people might say, where they can do party tricks, they can contort their bodies in different ways, and kind of impress their friends, or, you know, when they're out at recess, just drop into the splits without needing to stretch or try. And then we can enter more into the pain phase, where this typically, for a lot of people, is more that second decade of life, where there's joint pain, there's back pain, and then there's a decrease in hypermobility. So they might not be able to do the things that they once could do when they were younger. And then there's also a stiffness phase, where there's more limitation of joint motion and people notice more of that stiff sensation. And so this is where it can be tricky when I'm talking to someone who's, let's say, in their 50s and 60s, and I'm asking them about their joint mobility. Have they been told they've been really flexible? And they're like, yeah, 20 years ago, but now I'm in a lot of pain and I have more stiffness. You could still have hypermobile EDS and just be in that more stiff phase. And so that's something that I do think is really important to keep in mind just throughout the lifespan. And then next, gastrointestinal symptoms. This is where I do a lot of my focus for people with hypermobile EDS and people without. I treat a lot of gut health here. And so different symptoms that can be present for people are nausea. This one can be pretty significant. And this could be, again, from that dysmotility. So things are like not moving through as quickly as they should. A lot of these things can also kind of be linked to that. For either it could be gastroparesis or, again, just like slower motility in general. And then we have the IBS flavors. So we have diarrhea, constipation mixed. A lot of IBS is actually SIBO when you do further testing and further diagnostic workup. And so SIBO is small intestinal bacterial overgrowth. That is where there's bacteria in the small intestine that should not be there. So they, potentially migrated from the large intestine where we do want them. Now they're in the small intestine. And when they're in the small intestine, they can cause a whole host of symptoms, the most common ones being bloating, gas. Stools can be anywhere. So I've seen kind of the spectrum of normal bowel movements where it's coming out very easily, not much diarrhea or constipation, or it can be a mix of kind of everything, where some days you don't know. Some days you have diarrhea, some days you have constipation, other days your bowel movements are normal, and what you eat doesn't affect that. And so that's pretty classic with SIBO. SIBO we diagnose using a breath test. And yeah, if that's something that you think could be going on, definitely talk to your provider here at Living Wellness about that. Dysmotility is another symptom, GERD, esophageal spasms, and many, many more. So a lot of different GI symptoms can be directly related to hypermobile EDS. And so that's something that I started to ask more people about that end up having SIBO as we go through, okay, what could have caused this? Because if we don't know why it happened in the first place, we can treat it, but then how are we going to prevent it from coming back? And so that's something that, again, can be treated and can really, really help someone's quality of life and all of their GI symptoms. Okay, next one, so we have neurological symptoms. So dysautonomia, this is another more umbrella term where there is some dysfunction of the autonomic nervous system. Our autonomic nervous system is basically all of our involuntary actions. So our blood pressure, our heart rate, breathing, things like that, that we don't have voluntary control of. That's kind of the umbrella of dysautonomia. Most people that have hypermobile EDS, I don't want to say most people have POTS, but POTS is a very common comorbidity for people with EDS. And then there's two different types of POTS. There's primary POTS and then secondary POTS. Primary POTS, you have kind of three within that primary. So you have the neuropathic, the hyperaginergic, and then the hypovolemic. And these can all kind of like intertwine. And so it's not necessarily the case that you have just like one of these types of POTS, because yeah, they can you can have a little bit of each. And so POTS, again, this won't be totally dedicated to POTS. I probably should do another webinar on just POTS because there's so much that can be said about POTS. But that is something that I do commonly see occur with my patients that have hypermobile EDS. Dizziness, whether that's related to the POTS or not, is pretty common. Migraines, you can have intracranial hypertension or spontaneous hypotension, tethered cord, Chiari malformation. Some of these you're going to need some more advanced imaging with some pretty specific instructions going to the imaging, like a upright MRI where you're standing versus lying down. And so those are different things to keep in mind that, again, you can talk to your provider about if you have any inclination that this might be something that you're experiencing. Another thing I'll say here too is that my patients that have EDS are some of the smartest people I have ever met, and I have learned so much from them. unfortunately, I think it comes at the case of they've had so many conditions for most of their life, and they've been either gaslit by providers, they've been told, oh, this is just fibromyalgia, or this is all in your head, the worst term ever. And so they've done so much of their own research that they come in so equipped with knowledge and connections, and they're already connecting the dots themselves, because unfortunately they've had a lot of providers that weren't trying to connect those dots for them and just thought, oh, these things can't be related because they're in so many different body systems. And so I just wanted to mention that because that's something I learn a lot from my patients that have EDS, because sometimes they're bringing in these different articles and research, different things. And so just wanted to give a shout out to all my current patients that have EDS that have taught me something. And then this is going more over the nervous system. And so this is separating the parasympathetic from the sympathetic nervous system. Typically in POTS, we're kind of like a little more having these sympathetic nervous system symptoms. And so when we're addressing POTS and when we're addressing EDS too in general, we really want to try to balance the nervous system by tapping more into the parasympathetic, which is that rest, that digest, versus the sympathetic, which is more, again, that fight or flight. Okay, so gynecological or urinary symptoms, this list is not extensive. There's so many other things that can be said here, but pelvic floor dysfunction is definitely something that I commonly see. Pelvic organ prolapse, interstitial cystitis, or again, just like urinary frequency, urinary urgency, not necessarily pain with it too. And then PCOS and endometriosis. These are not links that have been fully sussed out in the literature, but it's something that I've been commonly seeing a lot of PCOS with my patients that have EDS, some of that endometriosis as well. And so that's something that I always keep in mind too. Okay, psychological symptoms. So there's more again that have been linked to EDS, and I again don't know how strong the literature is, but these are associations that I've seen and again that I've heard related to hypermobile EDS. ADHD, that one is pretty strongly established, but then also anxiety, depression can definitely be seen as symptoms of people that have hypermobile EDS. And then comorbidities. So this is something that I wanted to touch on because this is something that you might come across if you're looking up EDS, when you're looking up things that may be associated with EDS. A lot of these things too is that some of the symptoms that I mentioned previously could be more related to one of these different comorbidities occurring. So MCAS, for example, mast cell activation syndrome, that in and of itself can cause pain, that can cause dizziness, that can cause allergic reactions, that can cause urinary frequency and urgency. And so when I'm looking at someone's symptoms, I'm also in the back of my mind wondering, okay, is there also something else going on that's helping to explain some of these symptoms? And so there's the triad or the trifecta, which is hypermobile EDS, and then mast cell activation syndrome in POTS. So those are three very common things that go together. And then the pentad is adding on to that a little bit more, where we are including now autoimmunity and then gastroparesis. There's a great book that I have at the end, but it's called The Trifecta Passport. This is all about that triad. And it's, let's see, how many pages is this? 500 pages or so. So that is a book I'm about halfway through, so I can't talk about the whole book, but so far it's been a really, really good read. And then treatment. So treatment honestly depends on what symptoms are the most prevalent for that individual. So there's not like a protocol or something that I would recommend for everyone that has EDS. One thing, I guess, that I would be OT or PT. So that's typically something that I want most of my patients to have on board, because that can help so much if there's the pain, that joint instability, dislocation, subluxations happening. OT and PT can be so helpful in that arena. And so that, I would say, is one of the mainstays of treatment, is having someone on your team that has that focus. And then hydration and electrolytes. This I commonly see too when POTS is part of the picture. So making sure that you're drinking enough water to help increase that blood volume so you're less likely to have that dizziness, that fast heart rate with those positional changes. And then also electrolytes. So the recommendations for added electrolytes or added sodium specifically can be quite high. So they can range from 2 grams of added sodium a day up to 10 grams for some people. And I've seen even more in the literature. So that's something that I talk to most of my patients about. Usually, again, if they come to me with a diagnosis of EDS, they already tend to have those things on board. And then one medication that is used at a very low dose that can be helpful for basically all of the previously listed comorbidities that can come with hypermobile EDS is low-dose naltrexone. So that's something that I talk to most of my patients about to see, are they already on it? Have they tried it? Because that can be very helpful with pain. It's anti-inflammatory. It can help modulate the immune system in a way that's not going to suppress the immune system. And then at the bottom, I put, more of that focus on, okay, if POTS is more present, we're going to consider some of the lifestyle things, potentially some medications for POTS. Same thing with MCAS, same thing with GI. So I could give entire webinars on just POTS treatment alone, not even including POTS. And so that's something that, again, you can talk to me about. If I'm your provider, you can talk to one of your providers here at Living Wellness about to further dive into those different areas. And then mental health support I wanted to put on here. Nutrition is definitely a big piece. So sometimes I'll refer to a dietitian if we want some additional help around that, just because a lot of my patients too with EDS have more sensitivities to foods themselves, but then might also be hypersensitive to texture, certain variations of food. And so sometimes it's really nice to have a dietitian on board to help with that and to help create more of a, tailored plan. So that's like general treatment. And then let's see what I have. Oh yeah, nervous system regulation. Again, this is a huge, huge piece that I think can be so helpful for many people, especially if POTS and MCAS is also occurring with the hypermobile EDS. And so these are different ways that can help you tap in more to that parasympathetic nervous system. So deep belly breathing, humming, singing, gargling, meditation, cold water therapy can be helpful, but I put it in asterisks because if you have POTS, sometimes those extreme temperature changes can really trigger some symptoms. And so I would say don't experiment with that like on an extreme level without having someone nearby in case you do end up getting dizzy, feeling like you're going to faint with that cold water therapy. So that is definitely a strong asterisk on that one. And then flare tracking, this can be helpful to see, do you tend to notice flares around certain things? So that could be menstrual cycle days. Do you notice that certain days of your menstrual cycle, you're having more pain, or you're having more insomnia, or you're having more of those histamine symptoms, because histamine and estrogen have a very strong link. And so I do tend to recommend people keep some type of log or tracking system if they haven't made those connections of, when I eat this food, this happens, or if I fly, then that's a trigger for me, or again, like different times of my menstrual cycle. So there is an app called Guava, which can be really helpful if you are wanting to track flares. And so that's something to look into. And then this helps us also, again, like further suss out what triggers are in our control, which is what triggers are outside our control. So again, if we're flying and someone next to us has really strong perfume, some of that, I guess we could try to move seats, but like we don't necessarily have control of all of the things that may impact us and negatively affect us. And so that's another, I guess, little caveat that I wanted to mention there. And then establishing a care team, I think that's super, super important because again, like depending on what symptoms are more prevalent, you might want to have, a specialist on board to at least do some of the diagnostic workup and testing of other conditions that could be co-occurring. And so a musculoskeletal provider, so again, a PT or an OT, there is a great OT in the area that you've probably heard of if you have EDS. So I won't put her name on here, but if you are interested in that, I can definitely give you a referral. Having a good cardiologist, neurologist, gastroenterologist, allergist, rheumatologist on board, these can be helpful. Again, you don't necessarily need to have all of these people on board, but it's what is more prevalent, or do we want some more detailed workup to happen? So then we refer to someone that has, again, let's say like a cardiologist who specializes in dysautonomia or who specializes in POTS. And then, of course, a naturopathic doctor. Wanted to throw that in there because that's something that I think has been really helpful. I don't want to speak for my patients, but having someone that can, again, help look from this, wide perspective of, okay, how are those histamine symptoms maybe tied in with potentially SIBO? Can we treat the gut, and then are we going to see that those histamine symptoms get better? And so having someone who's going to look at the body as a whole, look at the body as, a very intelligent, individualized entity, and see that some of these things are connected, and see how treating those things may help other systems in the body. And so just wanted to give a plug for naturopathic medicine. And then resources, there's many more resources than these, but these I have found very helpful. So the EDS Society goes much more in detail on EDS, and then HSD. The Trifecta Passport has been one of the best books that I have found that talks about, again, the trifecta. So hypermobile EDS, POTS, and then also MCAS. And then recently I came across this hub by this amazing dietitian that I've listened to a few podcasts of hers, or ones that she's been on. And she has this highly sensitive body hub online. And there is information about each of those three conditions in that triad. And then also different suggestions to have, look a little deeper. I would say caveat there is if there are supplements recommended and you're one of my patients, that's something that we should run through together, because I am definitely not of the mindset of, just try anything. Because a lot of times, especially if there's that MCAS there, you can be highly sensitive and react to supplements. And so I typically like to start really slow with people, doing a lower dose than I typically would, or trying to find single herb products that don't have as many combinations, so we can see exactly what things you may tolerate or what things you may react to. And let's see, that's all. So I hope this was informative. I just realized that I'm matching the slide with my shirt. I didn't plan that, but you'll see I like this color. And if any of you have any questions, if you're my patient, please message me in the portal. I'm happy to answer any questions, or again, go through that diagnostic criteria if this set off some light bulbs for you. And then if one of your providers is, or if your provider is one of the other providers at Living Wellness, definitely talk to them about this. And I'm happy to consult with them if we need to do any cross care. So yeah, I hope all of you have a great weekend, and I will see you later. Bye.